Welcome to the 105th meeting of the National Advisory Council for Nursing Research. Of course, a special welcome to all our council members who we were seeing who was here just a couple of minutes ago, and of course to the NINR nursing science community. We're continuing with virtual meetings this round, so thank you for joining us virtually. We started to do this, but Dr. Old, do you want to do a formal roll call so we can see if we have quorum?
Yes, I do. So, Dr. Holmbeck, I believe, is not on yet. Dr. Johnson, and can you just speak so we know we can hear you? Okay.
I'm here. Good morning.
Chris Lee.
Good morning, everyone.
Good morning. Dr. Lewin.
Good morning, I'm here.
Good. Dr. Lowe.
Good morning.
Great. And Dr. Monroe.
I'm here.
Great. Dr. Moore.
I'm here. Good morning.
Good morning. Dr. Provencio Vasquez.
Good morning.
Wonderful. Dr. Wolf.
I put my camera off instead of unmuting. I'm here. Good to see
Good
everyone.
morning. Good morning. And Dr. Sullivan.
Good morning. I'm here.
And Nina, I believe she had told us ahead of time she could not attend. So everyone can hear, everyone can speak, and we have quorum. So we're good to go.
Excellent. Thank you, Susan. Good morning, everyone. So with that, let's jump in right away and go over a few logistics for today's meeting. This is a one-day virtual only meeting that's being broadcast live, and it'll be archived via video cast. Just a reminder to please mute yourself when you're not speaking to eliminate background noise. Closed session will begin about 15 minutes following the end of open session. A separate meeting invite was sent to council members and all applicable staff with login instructions for the closed session. And as per the roll call, we have one known absence, Dr. Nina Paragallo, and Dr. Holmbeck will be joining us a bit later. So minutes of the May Advisory Council meeting were made available in the electronic council book for your review, council members. Any discussion or any corrections to those minutes? Okay, speak now or forever hold your peace.
Sam, we're going to need unmuted for and approve.
Okay.
If everybody could just raise your hands, maybe maybe your virtual hand, and I can just scroll through and make sure that I see. Oh, good. They're all popping up.
So are these approvals then, or
yes,
questions about the minutes? Okay.
I think we're on approvals. I'm sorry.
Oh, okay. All right. So virtual hands for approval then. Great.
Thank you. We have approval.
Any opposed? If you want to unraise your hand, and any of those who want to oppose can raise their hand. Okay.
No opposed.
All right. So the motion to approve the minutes carries, although we didn't really have a motion. So
I'm so sorry.
That's okay. Do we need to do that, Susan, or can we move forward? Oh, we can't hear you now.
I'll just jump in and I move to approve the minutes, if that's helpful.
Thank you. Oh, yes, thank you, Mallory, saving us.
And I
Can someone second? Oh, thank you. Okay, now we're totally official. Very good. Okay, we have our approves. Very good. So the motion does now carry. And so just as a reminder, as well as we're thinking about the May meeting, the video is available on videocast for those who may have missed our May Advisory Council meeting. And you can find the video as well on the latest news page of the NINR website, along with links to other videos from prior council meetings. So dates for future council meetings are listed here, as well as on the NINR Advisory Council website. So please review and let me know if you have any known conflicts with these dates. That really helps us with planning if we know in advance. Our next meeting is scheduled for January 25th of 2022. At this time, I think we can probably consider that meeting will be virtual as well. I do also just have a couple of reminders. One is that as special government employees, council members may not engage in any lobbying activities while receiving pay from the federal government. Further information regarding conflicts of interest and confidentiality requirements are posted in the electronic council book. So please review those if you haven't already. And then Dr. Old, Dr. Old, it's true, will be giving us more specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. So with that, I'll move on to my director's report. So I do want to give you a brief update on some of the many activities here at NIH and NINR since we last met in May. Let's start with NIH news. President Biden has proposed the establishment of the Advanced Research Projects Agency for Health, or ARPA-H, to improve the US government's capabilities to speed research that can improve the health of all Americans. ARPA-H is included in the President's FY22 budget as a component of the NIH budget, with a requested funding level of $6.5 billion available across 3 years. ARPA-H will be tasked with building high-risk, high-reward capabilities or platforms to drive biomedical breakthroughs, ranging from molecular to societal, that would provide transformative solutions for all patients, revolutionizing how we prevent, treat, and cure diseases such as cancer, infectious diseases, and Alzheimer's disease. ARPA-H would use the DARPA model, so the Defense Advanced Research Projects Agency. So that'll be used as a model to establish a culture of championing innovative ideas in health and medicine. Dr. Collins and the White House Office of Science and Technology Policy Director, Dr. Eric Landers, as well as other leaders, published a commentary in the July 9th issue of the journal Science, which describes a vision for this new science entity. NIH and OSTP also have been holding a series of listening sessions to get feedback from patient advocacy groups, industry, scientific professional organizations, and other stakeholders. One of those was on July 30th, where advocates for nursing, as well as minority health and health disparities research provided comments. A video of that meeting, along with many of the other sessions, are on the NIH website. The most recent iteration of the NIH strategic plan is now available on the NIH website, covering fiscal years 2021 through 2025. It's an update to the previous plan for fiscal years 2016 through 2020. The strategic plan outlines NIH's vision for biomedical research direction, capacity, and stewardship by articulating the highest priorities of NIH over the next 5 years. In addition, it provides illustrative examples of accomplishments under the last plan and new initiatives under this new one. The strategic plan was developed through collaboration between leadership and staff across NIH and key stakeholders, including the research community, professional societies, advocacy groups, and the public. The NIH-wide strategic plan is designed to complement and harmonize institute and center strategic plans across NIH, which address their individual missions. And now some news of note from NINR. So while I'm on the topic of strategic planning, I want to give you a brief update on where we are with NINR's strategic plan. As a reminder, at the May Advisory Council meeting, the Council's working group presented their report, which included recommendations and a framework for future NINR research priorities. We've also been collecting feedback continuously through our website, and we've been really pleased at the large number of people who have taken the time to submit very thoughtful comments on where they believe NINR should focus moving forward. In addition, I've met with a large number of groups and individuals over the last year to tell them about my vision for the future and to hear their feedback on topics they think we should explore. So we appreciate everyone who's taken the time to send us their comments and their feedback. We'll continue to accept comments through our website until September 30th. So just a couple more weeks. So then what can you expect to see between now and January Council? I'm happy to report that we're well on our way to finalizing the draft framework for the new strategic plan, due in no small part to all the ideas we've received from the community. In the coming weeks, we'll be releasing that framework as an RFI and asking for comments on the framework. During the public comment period, which we expect to last about 6 to 8 weeks, we'll host at least one public webinar to gather additional feedback. We'll publish this widely through all our usual channels when the RFI is released, so please do keep an eye out for that. Once the comment period has ended, we'll revise and refine the framework based on the comments we've received, and our goal is to bring that revised framework to Council in January for discussion. We're still on track to release our new strategic plan in the first half of next year. So I'd like to start as well by thanking Mi Gyung-son for her terrific NINR Director's Lecture earlier today. I hope you were able to see it. Dr. Son is the Edith F. Honeycutt Chair in Nursing and Director of the Center for Nursing Excellence and Palliative Care at Emory University School of Nursing. She presented Addressing One of the Most Enduring Challenges in Healthcare, End-of-Life Decision-Making. Dr. Son discussed her research in developing and testing an end-of-life communication intervention targeting patients with chronic illness and their family caregivers, spanning all stages of the NIH stage model of behavioral intervention development research. So if you missed the live event, the lecture will be archived on the NIH videocast, and it should be available in the next few days. So there's a lot of news on the appropriations and budget front. The current fiscal year ends in just a couple of weeks on September 30th. On or before that time, Congress will need to pass and the President will need to sign a new appropriations bill. We anticipate that a short-term continuing resolution will be passed to avoid a government shutdown. For fiscal year 21, we received just under $175 million, which was a small increase over the previous year. That was also true for NIH. Please note that this NINR number is a little deceiving. In fiscal year 20, additional money was transferred to NINR for AIDS research. That is not reflected in this table. When we do account for that additional fiscal year 20 funding, the actual funding increase that we received in 21 was 1.5%. Also, please note that last year, NIH as a whole received a large amount of supplemental funding related to COVID that's not reflected in this table. The President released his full fiscal year 22 budget request back in May, shortly after the last council meeting. In that budget, the President requested about $52 billion for NIH, up from $42.9 billion in fiscal year 21. Of that amount, $6.5 billion is requested through Launch ARPA-H, which I talked about a little earlier. The request also included an additional $330 million for health disparities research to be split among several components of NIH. And we're very pleased that $20 million was requested for NINR in recognition of the impact that nursing science can have on health disparities. Now, if we're fortunate enough to ultimately receive that funding, we'll be ready. The concepts we'll be discussing later today could be supported with that additional funding. At the end of July, the House of Representatives passed an appropriations bill that contained funding for HHS, including NIH. And we're happy to see that the House included the full amount requested for health disparities research. The Senate has not taken action on the fiscal year 22 appropriations bill for HHS yet, but it may do so yet this month. The Senate and House passed bills will then need to be reconciled before being sent to the President for signature. NINR's 2021 Methodologies Bootcamp began yesterday with the first of 3 live broadcast sessions. The 2021 Bootcamp is exploring the impact that artificial intelligence has on the evolving healthcare environment to improve the care of all patients and families in an equitable way. The goal is to showcase how AI can improve outcomes and how to avoid unintended consequences that increase disparities. Yesterday's session focused on innovations and improvements in health outcomes. The session next Monday at 1 o'clock Eastern will center a discussion around the area of clinical applications. The third and final session on Monday, September 27th, will explore bias in algorithms. If you are unable to register, you can still watch the live broadcast of the remaining sessions. And a full agenda and a link to the live broadcast may be found on NINR events page on the web. On September 21st, NIH will host the Food Insecurity, Neighborhood Food Environment, and Nutrition Health Disparities State of the Science Workshop. Nutrition plays an important role in promoting health and preventing disease throughout our lives. But where we live or how much money we have affect our ability to access and afford healthy food. Ensuring food security and access to nutritious foods are key to preventing health disparities and diet-related diseases and conditions, such as cardiovascular disease, obesity, diabetes, and cancer. Understanding the role of socioeconomic conditions could help in these prevention efforts. This 3-day virtual NIH workshop aims to review the state of the science related to food insecurity and the neighborhood food environment, then identify research gaps and opportunities. Participants also will explore innovative research strategies that could inform policies and practices that help prevent diet-related health disparities, as well as promote health equity. The event is funded in part by the National Cancer Institute, the National Heart, Lung, and Blood Institute, the National Institute on Minority Health and Health Disparities, the Office of Disease Prevention, the Office of Nutrition Research, and NINR. In addition, on September 29th, our colleagues at the National Center for Complementary and Integrative Health will host a workshop on methodological approaches for whole person research. NINR is collaborating on this workshop along with NCCIH and many of our colleagues across the NIH. You can learn more and register for the event at the URL shown here. NINR is pleased to be helping develop a new trans NIH climate change and human health initiative. The effort is being led by the National Institute of Environmental Health Sciences. I serve on the executive committee together with the directors of NIEHS and several other institutes and centers. Dr. Chris Bao, Liz Peruccio, and Louise Rosenbaum represent us on the working group. So here's a little bit more about this initiative. Health is a critical part of climate change, but is too often left out of the discussion. The health impacts of climate change are closely tied to environmental exposures, existing health disparities, and structural discrimination. NIH research can provide essential input to enhance climate change policy and prevention programs at the local, national, and global levels. For these reasons, both the serious impacts and the significant potential benefits to health must be included in all discussions of climate change. And NIH is prepared to support research and analyses to inform these discussions. Our role is not to analyze the climate itself, but rather to build understanding of how climate change affects our health and how we can optimize climate change mitigation and adaptation to address the most pressing health needs. A recent request for information identified potential priority areas for climate change and human health studies to be supported by NIH, several of which are relevant to NINR supported research, highlighted here in red. So we certainly look forward to continued participation in planning this important initiative. In May, I shared that NINR was asked to co-chair a new fiscal year 21 NIH Common Fund program on transformative research to address health disparities and advance health equity. This program was developed under Unite. Funding decisions from the first two RFAs that came out in the spring will be announced soon, but a couple of brief updates. We published a notice that the RFA focused on minority serving institutions will be reissued with a proposed March 25th final due date for applications. Planning has also begun for a possible complementary Common Fund program with a fiscal year 23 launch. This fall, we'll be holding listening sessions and release an RFI to help inform this possible new health disparities research program. So we encourage you all to participate. Here are a few updates from our Extramural division on some of our recent activities. NINR is making significant investment in studying the social, behavioral, and economic impacts of the COVID-19 pandemic. We recently joined the leadership of a trans NIH initiative in this area. I'm serving on the NIH Executive Committee, and Dr. Amanda Price represents us on the working group. NINR is a major supporter of SBE R01 grants. These grants were supported under funding initiatives looking at community interventions to address the consequences of the pandemic among health disparity and vulnerable populations, and digital healthcare interventions to address the secondary health effects related to SBE impact of COVID-19. And here's a list of some of the awards we've supported in this area, with more to be awarded later this month before the close of the fiscal year. We recently signed on to a new FOA for 2021 focused on leveraging existing data. Of note, one of the interests we highlighted was research on the impacts of the COVID-19 pandemic on the health of nurses and other healthcare workers. Here's some information on a couple of new trans NIH initiatives that we'll be part of through fiscal year 21 and into fiscal year 22. One is the NIH Healthcare Systems Research Collaboratory. The collaboratory is designed in part to support the design and rapid execution of several pragmatic clinical trial demonstration projects. These projects address questions of major public health importance and engage healthcare delivery systems in research partnerships. Now we're joining the coordinating center in fiscal year 22 in the hopes of supporting additional meritorious studies. NINR staff help oversee 3 studies in the collaboratory. The 3 current studies are shown on this slide and focused on advanced care planning and non-pharmacological pain management. You may recall at the May Council meeting that we shared inclusion data for NINR supported studies by race, ethnicity, and gender. And we'll talk more about those data in a few minutes. The data showed a need to strengthen the inclusion of Latinx and American Indian Alaska Native populations in NINR supported research. To begin to address this, for the first time, NINR has joined the Native American Research Centers for Health, FOA. The NARCH program supports opportunities for conducting research and career enrichment to meet the needs prioritized by American Indian Alaska Native tribes or tribally based organizations. We're now providing support for an important study that will increase research capacity of community nursing, behavioral, mental health, and public health leaders at the Fort Belknap Reservation to engage in, design, and advance culturally competent methods for research projects focused on reducing health disparities among the Aani and Nakota tribes. Also, we recently signed on to a FOA on multi-level physical activity interventions. This is led by the Office of Disease Prevention, and the announcement highlights our interest in encouraging research to improve our understanding of how to increase and maintain health-enhancing physical activity using multi-level interventions and a wide range of population groups across the lifespan. Here's an update on some of our training efforts and our activities implementing recommendations from the Pathways report to strengthen the career pipeline for nurse scientists. In response to one of the Pathways recommendations to help reduce the need for outside work for students who may be balancing family and work, NINR raised the caps for requested salary for K01 and K99 applicants to $100,000 per year. In response to another Pathways recommendation to encourage early entry into doctoral programs and support streamlined degree programs, NINR joined the NIH F30 program. So the F30 program provides support for students at institutions with NIH-funded dual degree training programs. This will allow us to support nurse scientists pursuing joint PhD DNP degrees. So finally, I'll return to a topic we began to address at our last council meeting, something at the forefront of many discussions at NIH, and that's diversity and inclusion in our funded studies and in our research workforce. In May, I presented some data to you on the participants in our funded research studies. As a quick reminder, these data were from projects supported in fiscal year 16 through 18 and describe the study participants among our extramural grants. Today, I want to share with you some aggregated data on our grantees to give you a better sense of diversity among NINR supported investigators and how it compares to NIH supported investigators at large. So on this slide, all NIH supported investigators are on the left and NINR supported investigators are on the right. Note, these are two different sets of data and the year ranges don't match exactly, but it does give you an idea of what the numbers look like. For privacy reasons, these data are not publicly available. These were investigators on research grants, as I mentioned. The data do not include trainees. As you know, NIH has acknowledged that these numbers are not acceptable. For example, Black investigators make up only 2.4% of NIH-supported workforce. At NINR, that number is slightly better at 4.3%, but is nowhere near where it needs to be. Similarly, when we look at ethnicity, only 2.5% of NINR grantees self-report as Hispanic, while at NIH, that number is 4.8%. Our colleagues at the NIH Office of Scientific Workforce Diversity provided us with these data on R01 success rates from 2010 through 2020. NIH is in the blue, while NINR is in the orange. As is the case for NIH as a whole, success rates for white applicants to NINR are higher than for all other groups. Keep in mind, our R01 success rates across the board are lower than NIH because our overall success rates are lower. But that's a topic for another day. As I've described previously, and as you heard from Dr. Bernard back in May, NIH is concerned and is taking a number of steps to begin to address these disparities. But I think that we need to consider action closer to home. NINR and nursing science need to do better. I'm very interested in hearing your reactions to these numbers and these patterns and to hear your thoughts on future steps. So I'm going to pause my presentation and open up the floor to discussion.
Samantha, if you could unmute everyone, turn your cameras on so we can have a discussion. Thank you.
So Shannon, this is Eli. I'll start the conversation. And I know that you and I have discussed that there are some schools and colleges of nursing across the country that do a better job in really supporting and promoting minorities to do research in their not only nursing programs, but within their faculty. I think to identify those schools and colleges that do a great job and see their and really evaluate their history and their progress, I think would be a good start in looking at opportunities to explore in the future.
Thank you. Yeah, I agree. Other thoughts or reactions?
Excuse me. I think when we look at American Indian, Alaska Native data, I just think we need to maybe have a special focus or do something about these numbers. We're just so underrepresented, and I just think, you know, going forward, we could hopefully have some kind of a special focus and maybe think group or something, because our numbers just don't seem to be getting any better. And so I just think if we could do that. You know, at my institution, I have now 2 native nurse PhD postdocs and a junior faculty member. So there's 4 of us, PhD Native American nurses at my institution. And I think that's probably the most anywhere institution. So we talk a lot about needing a critical mass, and we're just struggling to, you know, try to understand and be able to move forward that way. And I think it's going to take a greater collective to be able to help us achieve that objective. Thank you.
Dr. Moore has her hand up.
Yes, thank you. And thank you for that wonderful comment. I was also wondering about looking at some of the more developmental funding opportunities, such as and the K99 ROO and some of those training mechanisms that might put someone in better position to go for an RO1, and wonder if we could have data on those types of initiatives as well, and think about some funding opportunities to target unique groups or, you know, diverse groups for those levels of funding opportunities, and not just jumping right to the RO1, which is obviously more challenging.
Thank you.
Dr. Monroe's next, I believe.
Yeah, I want to sort of echo what's already been said, that in many ways what we're seeing here is a reflection of the issue in mentoring and developing scientists from diverse backgrounds along the way. So, you know, the RO1 success rates for the past decade are sort of a legacy indicator. And the way to address them is really to focus early on the development of careers and career trajectories for nurse scientists.
Thank you. Dr. Lee?
First, I'd just like to say that I appreciate your being transparent with these numbers. So thank you for that. As terrible as they are, and I gave comments about particularly American Indian, Alaska Native, and potentially Native Hawaiian Pacific. Earlier in the pipeline, long before the RO1 phase. But I also wonder for our data presentation, it would also be important to see volume here. So for example, we don't know what that 0% means in terms of how many R01 submissions over that time actually were submitted. So just for our own internal data presentation, it would be lovely to also just see volume in each one of these categories.
Right. Dr. Johnson?
I also, for some reason my video is stopped by the host. I'm not using my video on purpose. It's not letting me turn it back on. But anyway, as I look at this, I also have noticed, there we go, no, I have permission. Hi, everyone. So when I look at these numbers, I also think about, and this is something I talked with Shannon about when we met, I see an opportunity for early career that through mechanisms such as the R25 that some other institutes use. And the way I think that can help in this setting is that we have, I know at my institution, we have abysmal diversity. We just don't have, and we're struggling, and it's, but what we're able to do is to see opportunities for, in particular, African American and Latino scientists at other institutions that maybe don't have the same research infrastructure and training infrastructure, and provide intensive training from our institution, but to those investigators who are often in very teaching-heavy positions and don't necessarily have the mentoring and resources. So to provide that as a way to help work with those scientists or would-be scientists who are in faculty positions early in their careers, but don't have the support for developing their work. And so I think there's an opportunity there. And they would have a harder time perhaps even coming for a K award because they don't have the mentorship within their setting. So I wanted to put a plug for that possible route as well.
Dr. Wolf?
Thank you. I am struck by not only the sort of lack of the diversity, but also even amongst white applicants, the sort of lower success rate. And to me, it may translate also into a gender issue, although I don't know what proportion of applicants are women. We know, generally speaking, in nursing, there are more women. And I'm curious what the factors are, I think sort of along the lines of an earlier question. Is it related to the budget of NINR? I mean, there probably are additional factors that we don't know that are not captured in this slide, for example. So it helped to better understand, but I do think that it may suggest that there is a gender issue as well, and I just wanted to name that.
Great. Okay. Dr. Lewin?
So I think that this is something to really consider. The additional factors which come to my mind is I would really be interested to know what is the correlation between the last slide and the diversity of the study section.
Good point.
Yeah, I think that's a good question. I think everything people are raising, warrants further investigation and thought to really understand the numbers we're seeing and more analyses. We could just give you a glimpse of some things today, but yeah, there's a lot more data that we need to look at and a lot of different explanations we need to think about that would inform our actions and our solutions. Does anyone else want to put any additional thoughts on the table or questions? Well, that was really helpful. Certainly, we think that we can do better and that we need to do better, not only in supporting a diverse scientific workforce, but also, including in our studies, the populations that bear a disproportionate burden of disease and risk. And as we said, there are many possible explanations, and understanding the data a little bit better, right, can help us guide our actions moving forward. You know, I really do want to keep these conversations continuing, and think about how we can monitor the situation as we move forward and as we develop actions to address this. So in that spirit, I'd like to put on the table the possibility that we form a couple of work groups, a pair of work groups of council to really do just what we're describing right now. One could focus, for example, on inclusion of participants in our NINR funded research studies. And the other could focus on addressing diversity in the NINR supported nursing science workforce. So what are your thoughts about forming a couple of working groups of council? I see some head nods.
Great idea. Great idea, Shannon. Great idea.
Both accounts.
Awesome. Thank you. All right, great. Well, thank you so much for those thoughts, and we'll continue this conversation in part through these working groups. And so we'll be in touch with you and as we form these groups. So thank you. All right. So let's wrap up. Just a couple more things. Couple more updates on what we've been doing here at NINR as a staff that I want to share with you. So as far as updating you on my activities, the summer months continued with meetings and presentations, including more meetings with members of Congress. Some of those recent meetings are listed here on the slide. In addition, since May, I've had meetings with, as I said, several members of Congress. In June, I joined NIH Director Dr. Francis Collins, Dr. Eliseo Perez-Estable from NIMHD, and Dr. Gary Gibbons from NHLBI for a briefing with the Congressional Black Caucus, where we had a chance to discuss the President's request for health disparities research funding. In July, I joined Dr. Collins again, and this time Dr. Diana Bianchi from NICHD, and Dr. Janine Clayton from ORWH for a briefing with the Black Maternal Health Caucus to describe NIH's activities related to maternal health and morbidity, including the NIH Improve initiative. This caucus is co-chaired by Representative Lauren Underwood from Illinois, who, as many of you know, is a nurse herself. And this briefing actually followed a meeting that I had with her earlier this year in May. Also in July, I met with Senator Jeff Merkley from Oregon. Senator Merkley is a longtime champion of nursing and is co-chair of the Senate Nursing Caucus. We had a great conversation about nursing science and future research areas, and we were actually even able to discuss our experiences in Rwanda. We also had a briefing scheduled in July with the House Nursing Caucus. Drs. Collins, Perez-Estable, and Bianchi were scheduled to attend that briefing as well. Unfortunately, due to other business on the Hill, it was postponed, but will hopefully be rescheduled for later this year. So I would say all these were really positive meetings where I was able to share and talk about my vision for NINR moving forward and to answer their questions. So I am so pleased to welcome Olga Acosta, who joined NINR on August 15th as our new executive officer. Welcome, Olga. Olga has 30 years of experience with NIH, starting her NIH career in 1991 as a contract specialist in the construction contracts branch within the Office of Research Services. Olga most recently served as the acting deputy executive officer at NICHD, as well as serving as the director of acquisitions. So we're so thrilled to have Olga with us. I'd also like to publicly welcome the new staff who have joined NINR since the May council meeting. They've all jumped right in during clearly challenging times and have already made critical contributions to the work of the Institute. So welcome to all of them. At the same time, I do want to let you know that Dr. Jessica Gill has transitioned her lab to Johns Hopkins University. As you know, Jessica was a Lasker Clinical Research Scholar. The goal of the Lasker Scholars Program is to nurture the careers of excellent clinical researchers. The program has 2 phases. A first phase that supports scholars in the intramural research program, and a second phase that can be at an extramural sponsoring institution. So Jessica will be completing the second phase of the program at Hopkins. Jessica's research in traumatic brain injury will be instrumental in better understanding and treating those with these often life-altering injuries. NINR is proud to have supported Dr. Gill's training and her work, and we thank her for her many contributions to the Institute, and we look forward to following her achievements in the future. And finally, an update on hiring on key leadership positions at NINR. I already mentioned Olga Acosta's arrival as our new executive officer. The searches are moving forward for the next permanent scientific director, clinical director, and director of the Division of Extramural Science Programs. Applications will continue to be accepted until each of those positions is filled. And I'm also pleased to share that recruitment of the next permanent deputy director of the Institute will begin soon. So please look for more information in the coming weeks, and we'd really appreciate your help disseminating information on that position widely. And of course, for the latest NINR news, please check the news and notes feature of our website. To make sure you're always up to date, please consider subscribing to our Gov Delivery email service, which you can do on our website. And with that, the next item on our agenda is a presentation about the NIH Office of Nutrition. So let me pause to see if Dr. Lynch is here yet.
Yes, I'm here. Thank you.
Excellent,
Cheers.
Excellent. So I'm gonna stop sharing my screen, which will allow us to start pulling up Dr. Lynch's slides. But let me do a quick introduction of Dr. Lynch. Dr. Christopher J. Lynch was appointed the acting director of the NIH Office of Nutrition in January of 2021. In this role, he directly manages and supervises complex programs in nutrition research and participates in the development of new trans-NIH funding initiatives and workshops. Before joining ONR, Dr. Lynch was at NIDDK, where he held the dual role as chief of a new nutrition research branch of their Digestive Diseases and Nutrition Division, and director of the Office of Nutrition Research. In that role, he served as the executive secretary of the Nutrition Research Task Force, which developed the first ever strategic plan for NIH nutrition research, and stood up seven trans-NIH implementation work groups to guide its implementation. He also collaboratively led efforts to develop a common fund project that was announced in 2020, Nutrition for Precision Health, powered by the All of Us research program and representing the first ancillary study nested in All of Us. So thank you, Dr. Lynch, for joining us.
Cheers. Thank you, Dr. Zink. Yeah, so I'd like to introduce the new NIH Office of Nutrition Research. I'll speak a little bit about NIH nutrition research and our office implementation of the 2020 to 2030 strategic plan for NIH nutrition research. And then I'd like to speak a little bit about this common fund project we are coordinating, Nutrition for Precision Health, that Dr. Zink mentioned. So nutrition is a cross-cutting topic across many institutes and centers. In 2020, there were over $2 billion in expenditures in nutrition research and over 5,000 projects. So this, sort of presented an opportunity for strategic planning and improved coordination that, my office, hopes to work on. And so in January of this year, Dr. Collins announced the move of my office from NIDDK to a coordinating branch of the Office of the Director, Deepa Kipsey, and to enhance engagement of NIH institutes and centers in implementing the strategic plan, which many of them worked on at any rate, and to develop new collaborations and relationships focused on nutrition research within and outside the NIH. So the mission of our office is to advance nutrition science to promote health and reduce the burden of diet-related diseases. Our responsibilities, including advising NIH leadership on matters relating to nutrition research, to coordinate implementation of the strategic plan for NIH nutrition research. And to do that, we try and identify research topics that deserve expanded support and effort within the ICs. Within the Office of the Director, we can't directly fund projects, so we have to work with the ICs to identify homes for projects and collaborators to lead them within an institute such as NINR. And then we develop and lead and manage trans NIH nutrition research projects in cooperation with the institutes and centers. And we lead and represent NIH on interagency committees on nutrition research, such as the Interagency Committee on Human Nutrition Research, which is co-chaired by the Assistant Secretary of Health and the Chief Scientist of USDA, and another interagency committee called that's has a larger membership, the Nutrition Research Coordinating Committee. So last year, we released the first ever strategic plan for NIH nutrition research. After we developed this, we were asked by the Office of the Director, well, what's the bottom line? What's the what's a unifying vision for it? And as we we're looking through it to identify that one that sort of immediately emerged was precision nutrition by and this was really not by design so much, but that is just it became a common theme of all the strategic objectives. So this plan has 4 strategic objectives. The first is to spur discovery and innovation through foundational research, and this isn't just preclinical research, but also clinical research to do things like look at diet and host microbiome interrelationships, to improve the bioinformatics of nutrition-related genes and pathways. And so it asks the question, what do we eat and how does it affect us? And then the second strategic objective is to investigate the role of dietary patterns and behaviors for optimal health. And so it asks a question of what and when should we eat. So we're interested both in food-based dietary patterns, but also time and other kinds of dietary patterns, such as circadian patterns, time-restricted eating, and intermittent fasting, for example. So what and when should we eat? And then the third strategic objective is to define the role of nutrition across the lifespan. How does what we eat promote health across our lifespan? So this part of the plan focuses on 3 areas of the lifespan that have previously been, less well studied, let's say, and this includes a pregnancy, birth to 24 months, and healthy aging. So the kind of projects that are described in here include things like developmental origins of health and disease, and another sort of project related to that is human milk composition. So we know more about, the federal government knows more about what's in a strawberry or a banana than we do about human human milk. And so these projects actually have been, as we involve stakeholders for this plan, were very much wanted by other federal agencies that are trying to do dietary guidelines for pregnancy, birth to 24 months, and the other age end of the life spectrum. And then the fourth strategic objective is to reduce the burden of disease in clinical settings, in hospital settings, and outpatient settings. How can we improve the use of food as medicine? And so one of the areas here is how a person being malnourished, either with micronutrient malnutrition or macronutrient malnutrition or over nutrition, which causes an inflammatory burden and micronutrient deficiencies. How does that impact the outcome of clinical care? How does it allow a person to respond or not be able to respond to, for example, cancer chemotherapy or things along those lines? Now, this is an area. This is sort of an area where one would think that NIH was led the way in. But as we looked across our portfolio of grants, it's actually an area where there's a great opportunity to expand our research. In addition to these four strategic objectives, we have a number of cross-cutting research areas: minority health and health disparities, I mentioned a few minutes ago, health of women, rigor and reproducibility, data science, system science, and artificial intelligence, and then training the scientific workforce. Now, in order to implement the strategic plan, we have stood up a number of implementation working groups. So these include generally about 19 or 20 participants, usually program staff from across NIH, and also in some cases some subject matter experts of NIH intramural scientists. And so we have one on foundational nutritional science, another one on nutrition and health disparities, microbiome, diet, and health interrelationships, nutrition across lifespan, implementation science, implementation of programs, practices, and behaviors. And so this group here is interested in things like, we can sometimes cause behavioral change for a period of time, but then the problem is, maintaining those healthy behaviors over a longer period of time. So this group works on those kind of things, and also implementation of things. So let's say, we have this group that works on nutrition and health disparities. The implementation science group might work on, how to implement the research that emerges from, the nutrition and health disparities working group. And that is actually a very good example of precision nutrition, because, how you implement something, in rural Texas or the South may be very different than how you would do it in Los Angeles or in Eastern city. So those are some of the kind of matters that they work on. And then our final one is on medical nutrition, which is tackling this fourth strategic objective. So in our work, we've been trying to keep our eye on the ball here. That since after we released the strategic plan, we had this COVID epidemic. This is a paper that was in Cell, which described this problem that researchers around the world have been shifting their attention to the COVID outbreak. We continue to be afflicted by numerous other diet-related chronic diseases in increasing numbers, and of course, many of those with those diseases were at much greater risk for morbidity and mortality from COVID-19 infection. So here's an example of one of our implementation work groups, Nutrition and Health Disparities. It's led by, co-led by Allison Brown at NHLBI and Tanya Agres Collins at NCI. And you can see the membership of this group here. They seek to advance NIH research to understand the interactions between diet, nutritional status, the environment, and biological and behavioral processes and how they contribute to health disparities. One of the things that this group has done is to develop a sort of a document or guidebook about how, showing the other groups, how they could, look at these questions of nutrition and health disparities within their own, in the disciplines that they are tackling, such as microbiome research or foundational research. They've also we have worked with them to develop so we provided support for them to develop a workshop, which is next week, on that Dr. Zenk is speaking at on food insecurity, neighborhood food environment, and nutrition health disparities, state of the science. This workshop already has over 3,500 registrants and over 200 poster presentations for this virtual 3-day meeting. Now, sort of going along with this workshop or dovetailing it, we've developed a request for information that we hope any of the members here, council members, might provide input to research opportunities to end hunger, food, and nutrition insecurity. And so that was released last week. Now, finally, I'd like to discuss a little bit about this Common Fund project we've coordinated. So this Common Fund project addresses one of our strategic objectives to develop and validate algorithms to predict what all of us should eat. I think we're all familiar with these situations where we put groups of people on weight restriction diets, and some of them will lose weight and be able to maintain it over time, and other ones will start tracking back to their original weight. We had this NIH study called Diet Fits, where we provided people with either a calorically restricted high fat or calorically restricted high carbohydrate diet. There, in each arm, people lost an average amount of weight, but as we looked across individuals, we saw that some people, actually gained weight on one of the diets, or they lost a huge amount of weight. There was an incredible amount of inter-individual variability in these responses. And so we think that's, we need more research to understand the basis of this inter-individual variability. And this is one of the goals of this Nutrition for Precision Health Common Fund project. So the primary goal of this is to develop algorithms to predict individual responses to foods and dietary patterns. There's already some commercial startups which say that they are able to do this. And so it's in a sort of public interest to find out if that is true, and to identify those things which might predict people's responses to diet interventions. And so we're going to be using a comprehensive set of microbiome, genomic, physiological, metabolic, behavioral, cognitive, contextual, EHR, survey, environmental data in a large and diverse population of participants. The secondary goals are to improve our dietary assessment methods, which for my office is sort of our elephant in the room. There's always these complaints about the dietary assessment methods, food frequency questionnaires, and things like that. And so we're going to work, as part of this will be under, in domiciled feeding studies, to work to try and sort out what are the issues, some issues associated with those. And it also will represent a nutrition science discovery engine. All of the data is going to be made immediately available for the public to investigate and interrogate. So this is a Common Fund project. I'm sure you're all familiar with those. They, of course, Common Fund projects have to be transformative. They have to have the potential to dramatically benefit biomedical or behavioral research. They must achieve a defined set of goals within 5 to 10 years. And so the first 5 years of this program, the goal is to develop these algorithms, and in the last 5 years to see if those algorithms actually work. And they have to be synergistic to advance the individual missions of institutes and centers. And again, nutrition is a cross-cutting research area across multiple institutes and centers, and would have to require a coordinated approach. And it has to be unique in that no other IC would be likely to be tackling this. So I'm sure you're familiar with some of these other Common Fund projects, such as the Human Microbiome Project, MotorPack, the Science of Behavioral Change, and the Pioneer Award program, the Metabolomics program, and others. So this program is going to be nested in the All of Us research program. So this has required really a lot of coordination. Not only do we have to coordinate and talk the Common Fund people into working with us on this study, but we had to also convince a cohort study, the All of Us research program, to allow us to access their participants. So the All of Us research program has diversity at the scale of 1 million people or more. It focuses on participants as partners, and many of the participants have characteristics that are uncommon in normal research subjects. So their character, most of them would be have characteristics that would not usually be found in research studies presently. So it's a very diverse set of participants. They've worked very hard to do that. It has a longitudinal design, which means that things we do today will be able to, maybe look forward at these participants later to see what kind of outcomes and health changes that they've had. And we have the ability to sort of recontact them to ask them if they'd like to take part in our study. There's multiple data types available in these participants. These include live electronic health records, and these health records have been harmonized by All of Us across different platforms, which is actually a problem that many of the institutes and centers at NIH are interested in solving. But actually, All of Us has already developed tools to harmonize these various electronic health systems and allow them to be, us to interrogate them. They include surveys, baseline physical measurements, specimens, and also, each one of these participants has had their genome completely sequenced, and that data has been converted to things like SNPs and so on. And so that is a huge expense and cost savings for any director who wants to do a study, to already have the participants genetically characterized with CLIA certified medical genetics and these live electronic health records. So this is a national open resource for all. It's broadly accessible to all researchers with open source software and tools. And our program will be adding new tools to study microbiome and metabolomics, and it has security and privacy safeguards for all of the participant data. Our study that has a modular design. In module 1 for 2 weeks, we'll be examining participants' diet and physiological responses to mixed meal challenges. So we'll be looking at their usual diet. We'll be looking at this with both what we call an ASA24, which is an 24-hour recall that's was developed by NCI, and also a technologically assisted dietary assessment tool that's being chosen now from the grants that came in. So they'll be doing many 24-hour recalls over a 2-week period, and then they're going to be instrumented up with whatever the research community decides during the planning year, and in terms of surveys and physiological apps to look at heart rate variability or continuous glucose monitor, or whatever the team comes up with. And then we'll be examining physio-metabolic responses to mixed meal challenge. In the second module, 1,000 to 1,500 of these participants will, 1,000 to 1,500 of those will examine responses to 3 short-term intervention diets in freely controlled feeding studies. So these will be controlled feeding studies, but there'll be feeding studies in which people can, go home. They won't be domiciled. And so these are going to be of sufficient length to allow opportunities to see changes in the beta diversity of the microbiome. And then in the third module, we're going to be domiciling 500 to 1,000 participants to examine the responses to these same diets. But because we'll be domiciling these people, we'll be able to do far more interventions in them per day. For example, maybe multiple 24-hour urines, or multiple stool collections, or things like that in them. And then at the end of each of these intervention diets, they'll be getting again a mixed meal challenge. So in all 3 of the modules, we'll be collecting microbiome, physiological, metabolic, behavioral, contextual, cognitive, environmental data, and leverage the existing genomic, EHR, and survey data in all of us, and conduct these mixed meal challenges to model the impact of diet and dietary patterns on physiological, physio-metabolic responses. And we're going to be using machine learning and artificial intelligence to develop these predictive algorithms and to address other questions. This is the structure of the program. We have a research coordinating center, which will work closely with all of us as participant technology system centers, which is the one who incorporates apps and things like that into the participants' mobile device to interact with them, and provides the software to interact with the participants during the study. Oh, remember to take this measure today, or to fill out this survey, or something like that. And then they're also going to work with the All of Us Data and Research Center, which is where the data is ultimately stored. All of the data has to stay in the All of Us Data and Research Center. It can't be exported out of that the researcher's workbench. Then we are also providing additional funds to the All of Us Biobank, because they're going to be collecting more and different types of samples than they've collected before. Currently, All of Us does not collect samples for microbiome analysis. We have a metabolomics and clinical assays center, a microbiome and metagenomics center to look at microbiome ecology, and then a dietary assessment center, which will provide instructions to the clinical centers on the dietary assessment devices, and will be providing instructions on how to do doubly labeled water studies, so we can match up what people say that they eat with the energy expenditure data from the doubly labeled water. We plan to fund 5 to 6 clinical centers. These are either going to be at the same home institution of some of the All of Us research centers, or they're going to start a new All of Us recruitment center at their university. And then finally, we have an artificial intelligence, multimodal data modeling and bioinformatics center. This is a very large grant that we'll be funding, and this will help address help the investigators address questions in addition to the main question of developing predictive algorithms. So this we had a workshop in January and then subsequently had funding opportunity announcements. The applications were received in April and they've already been reviewed, and the program staff and coordinators are currently working on selecting the awardees, and the awards will be made in probably in December or January of 2022. And then the first participants we hope will be enrolled in 2023. Like all Common Fund studies, you can learn more about it at the Common Fund website, which links the link to which is here. And then finally, we have engaged many program staff across NIH to help us work on implementing the strategic plan. The folks from the NCI Cancer Institute, would normally be going to cancer meetings. People from NIDDK would be going to, diabetes or kidney meetings. And they haven't really been able to do that, since the pandemic started. So we recognize that opportunities for the nutrition research community to engage ad hoc with NIH staff, not just our office, but other staff, has been limited. And so we've developed this listening sessions program where either companies or trainees or scientists or departments or other research groups or institutes from universities have something that they would like to do or have questions about their future or things like that. And so we try to have an initial conversation with them, and then after that find the right people for them to talk to at NIH and bring them together to have one of these listening sessions to help overcome this problem of us not being able to meet with you at meetings. And so to do that, we ask people just to send a note to nutrition research at nih.gov. So yeah, that's all for me, and I'm glad to take questions. Thank you.
Thank you, Dr. Lynch. We've asked Dr. Moore to lead the council discussion and questions.
Yes, thank you, Dr. Lynch. That was very informative. Could anyone who has a question or comment, please raise your hand? I hope I'm not missing anyone. I would like to start, Dr. Lynch, and come back to your strategic plan and the focus on medical nutrition, and wonder if that is more broadly related to health-related nutrition, and thoughts about the role of nutrition, for example, in symptom management and symptom management, self-management, and just trying to think a little broader than medical nutrition.
Well, I think it's nutrition in clinical settings.
Oh, okay. Yeah.
And so, so one of the things I think there's been a number of federal reports, for example, that and I think it's a concern for hospitals that CMS has these plans that if you have a patient who's been readmitted for the same problem, within 30 days or something like that, that they're going to, decrease your bulk, bulk payment. And so many of those readmissions are related to the fact that people are, probably malnourished and their malnutrition was not assessed. I mean, I'm sure all of us have had, a family member or something like that who, had a cancer diagnosis, but before that cancer diagnosis, they had maybe, they felt bad or something. They couldn't put their finger on it. It was, maybe some kind of diffuse pain or feeling, or, they just, just felt tired or something like that. And they over time become malnourished. And then by the time they get their cancer diagnosis, they're may already be significantly malnourished, and they're not in the best state to be then starting to take radio or chemotherapy to combat their disease. And frequently this is just something that's not addressed, and we see it a lot in cancers and other things. And then I think in terms of prevention, I think most people are aware that smoking cigarettes cause cancer, that being in the sun without sunblock causes cancer, but there's a much smaller number of people who realize that obesity and overweight is a cancer risk, and doctors don't want to talk to people about being overweight. They and maybe if they said, well, I'm worried about you getting cancer or something. So these are the kind of things that this group is working on. There, the various societies that are interested in this, such as the American Society of Parenteral and Enteral Nutrition, the American Society for Nutrition Medical Nutrition Council, and the Academy of Nutrition and Dietetics, indicate that one of the problems that exists now is that they recognize that there's a number of people who once they're diagnosed as having malnutrition, that only some of them will actually derive a benefit from getting that malnutrition corrected. And they would like, just as we're trying to do in our study, to identify who, to use omic approaches or something like that, to identify those people who are at risk for not having an intervention. And, and that just comes back to, quality. And so, quality of care that, is, providing that intervention worth the funds. And if you can, perhaps target it better. So these are the kind of things that the group is tackling. And I think there's a lot of opportunities. This has been an under, funded area, and, the societies and things have been, funding it on their own. And I think, it's a time for us to, step up and step in.
Thank you. Dr. Lewin.
Okay, sorry, I think I had to unmute myself. I only have a couple of words to say. It's a very, very timely presentation and very clear, very lucid. And I see a beautiful synergy with Dr. Rasuli's presentation, which is coming later, about the algorithm bias. That would be something which is really worthy of looking into.
Yes.
Thank you. Are there any other questions or comments for Dr. Lynch? Well, thank you, Dr. Lynch. I'm not seeing any other hands raised, so I'll turn it back.
Okay. Well, thanks for having me.
Thank you, Dr. Lynch and Dr. Moore. Appreciate that. So we're going to go on break then until the top of the hour. So that's 1 o'clock Eastern, so about 35 minutes from now. So council members and colleagues, will see you in about a half hour. Enjoy your break. Welcome back. Susan is going to help us to do a little roll call somehow, however she prefers, before we get started.
Right. So just on the screen, we're missing a few. So Dr. Holmbeck did join us, but I don't see him back from break yet. Dr. Johnson, I think I saw you. Yes. Okay. Dr. Lee, I don't think he's back from. There's Dr. There they are. Okay. Dr. Lewin.
I'm here.
I wasn't sure how. I keep clicking on something, and then I get asked if I want to be a panelist or something. I think I must have the wrong link.
Nope, that's right. Just accept being a panelist, and then we can see and hear you. Dr. Lowe, I think I saw you. Yes. Dr. Monroe, yes. Great. Dr. Moore.
Present.
Ah, there you are. Dr. Provencio Vasquez, there you are. Dr. Wolf. I saw her briefly, but now she has disappeared. There she is. Is her, Joan, is your mic on?
Here.
There you are. Great.
Thanks.
Now, did we lose Dr. Lee?
I'm here, Susan.
Oh, there you are. Okay. All right. We are here and have a quorum.
Excellent. Well, welcome back again. And I am very pleased to introduce our next speaker, Dr. David Wilson. Dr. Wilson was appointed as the first director of the Tribal Health Research Office, or THRO, in January of 2017 here at NIH. In his leadership role, Dr. Wilson brings together representatives from the NIH Institute, centers, and offices to leverage NIH resources and build collaborations through the research portfolio to address tribal health concerns. He works to build a unified NIH presence with which to engage and ensure input from tribal leaders across the nation, and aims to expand training opportunities for American Indian and Alaska Native communities. Dr. Wilson comes from the NIH Office of the Director, from the Department of Health and Human Services Office of Minority Health, where he served as Public Health Advisor and the American Indian Alaska Native Policy Lead. I have the pleasure of co-chairing the NIH Common Fund Program on Transformative Health Disparities Research with Dr. Wilson, and I'm so glad that he could join us today. Dr. Wilson.
Great, thank you so much, Dr. Zank, and it's a pleasure to be here with you all, council members. My name is Dave Wilson. I am a member of the Navajo Nation, and I am the director of the Tribal Health Research Office. And I will start here by sharing my screen so that you can see. I hope everybody can see the presentation or the slide that's up. One of the things that I'd like to mention right off from the get-go is that this is the first logo or image that you're seeing that we've developed in the office. And we developed this specifically to help describe the function of our office. And Dr. Zank did talk about some of the functions that we carry out. Our office, very much like Dr. Lynch's that you heard before the lunch break, our offices serve as coordinators. We have a coordinating function across the agency. And here you can see this is a dream catcher that's depicted here with all the different institutes and centers that surround our office. And so we work together, we coordinate a lot of different efforts and initiatives that are important to tribal communities and tribal research. You can see here hanging below in the feathers and the beads, some of the things that we're really focusing in on, which are careers in research, development and establishment of programs, the refinement or development of policies that are applicable to tribes and biomedical research. And also it's really important for us to incorporate communities into this process we call research. So that's just a little bit about our logo, and I'm going to jump right into this. And I think it's really important when we begin having this conversation about working with tribal communities, we really need to set the stage and provide a little bit of context around this. So before the formation of the Union, all North America was inhabited by American Indians. And so as a result of the establishment of the Union, you can see here that the developing federal government has always recognized tribes as sovereign nations. And that's really important because that defines a very unique relationship. It's a government to government relationship. And here you can see I put it, one of the arrow points here in big and bold letters is that the relationship is political and it's legal. It's not based on race. And this is really important to consider when we hear about things around developing programs that are specific for a specific race or ethnicity. Well, tribes are not included in that because of our specific and special relationship with the federal government. It's also important to really recognize that there's not just one tribe. So when we think about program development and policies and initiatives to engage tribal communities, that there are 574 federally recognized tribes and about 66 or plus or minus a few of state recognized tribes. And all of these tribes are very unique. There's a lot of diversity within each of our different communities. Something through our, I guess would be considered a trial and error process, is that we really realized that the structures and the governments are really set up differently. And it's really important to take those in consideration when we're thinking about engaging tribes for participation in biomedical research. It's also really important to think about the language and cultures when engaging tribes in terms of research. So I know that we've all been talking about strategic plans, and I'm going to show you the cover here of ours. This is from FY19 to 2023. This was the first trans NIH strategic plan for tribal health that our office put out. In the next slide, I will talk about the strategic goals, but you can see here that our office, like Dr. Zink had mentioned, was established in 2015. I was appointed as the first director in 2017, and our office really serves as the primary contact for tribal nations on all facets of biomedical research. So we get questions around funding opportunities, we get questions around policy implications and impacts. We also get questions around process for the establishment of tribal IRBs. So there's just a wide range of questions and concerns that we get from tribes as it relates to biomedical research. So it's really important for us to partner closely with the other 27 institutes and centers, all 27 institutes and centers, on some of the questions that are brought to us to make sure that these ICs are in close communication so that they can help us work with these communities to develop better relationships so that we can thereby increase their participation in funding opportunities and research that's supported by the agency as a whole. Something else that our office is tasked with is that we ensure that the NIH adheres to the NIH guidance on the implementation of the Health and Human Services Tribal Consultation Policy. Now, this is a really big topic and the really important thing. The tribal consultation process is a formal process of engagement where the highest levels of a government have conversations around policies, programs, and issues that are deemed to impact, significantly impact tribal communities. So I'm happy to report that our office has been working very closely for a couple of years with our council, and I'll talk about them a little bit later. But we've developed our own NIH specific policy because the work that we do is very unique as it pertains to research. So it was really important for us to have a more customized tribal consultation policy that all 27 institutes and centers would be able to look at as a roadmap on how to effectively and respectfully engage with tribes during this consultation process. Something else that we are tasked with doing is making sure that tribes are allowed meaningful input during the formation of these policies of programs and in the development of different priorities. So next year, our office will be leading a national formal consultation with all tribal nations on the development of the new strategic plan, which will be from 24 to, let's see here, to 28. And so we're looking forward to that process as well. Something else, I talked a little bit about our NIH Tribal Advisory Committee, which is basically our council. And they are tribal leaders from across the country. We convene them very much like Dr. Zink convenes this really important council. And they serve as really important advisors for the work that we do. So the next slide is more about the strategic goals for the agency as it pertains to tribal health. And as you can see here, there are 4 strategic goals, and we use the medicine wheel to help us clearly communicate how important this holistic approach to addressing all of these is for tribal communities. We can't do one without thinking or acknowledging the other, because without that, we have an incomplete will, and it's going to be far less effective. And so these are very large and broad areas for engagement or priorities. And we can definitely see many different areas of opportunity for us to be engaging with NINR, considering the importance of the nursing careers and the profession in tribal communities, in rural communities where many of our community members live. You can see here, number 1, enhancing communication and collaboration has been absolutely paramount. You know, our first priority when we set up the office was to make sure that tribes knew that we were here. And I'm really glad that Dr. Zink invited us. So now that this council knows that this office is here and serves as a resource for engaging other parts of the agency. I'm also thinking about one of the things that we've been doing in communicating with our internal NIH community is the approach where we engage tribal nations and ask them, what are their research priorities, and be able to link up different institutes and centers with the priorities that are identified by the communities. I think that as a scientific community, classically what we do is that we dictate or we identify an area of our research or scientific expertise or interests and go into communities with that thinking that this is how we're going to help broaden or improve health in these different communities, when actually it should be the opposite, where we should be listening to the communities and hearing about what are their priorities and then making those connections and bringing in and making those connections for collaboration and research. Another area is building research capacity, something that's really important. A lot of communities are really interested in participating or building research capacity within their own communities. I think our experiences with COVID-19 has really highlighted our inability to actually effectively attract and monitor outbreaks within our communities. And so thinking about how do we do this, and Dr. Zink mentioned the office with the opportunities around data science and artificial intelligence and machine learning. Well, these are all new initiatives that we're also pursuing with the Office of Data Science Strategy. One of the great things that we've been able to do is partner with ODSS to provide additional funding to an academic institution to develop a data science curriculum for tribal colleges and universities. And our goal is to pilot this program to see where we can improve it, with the ultimate goal of expanding it to all 32 tribal colleges and universities, thereby increasing the capacity for these communities to be able to conduct their own research by their own tribal community members. Also, expanding research is critically important. Many communities just aren't aware of really what's out there, and our job is to really bring the cutting edge science to the communities so that they have an opportunity to exercise their sovereignty and say, you know what, this is really important for our communities and we would like a chance to participate in these different types of research. So expanding research is also a critically important part of this strategic plan. And I think most importantly, that all of this has to be done with number 4 here, enhancing cultural competency and community engagement. Without respectful engagement, then we run the risk of doing again what has happened in the past with unethical research with tribes. And this is what has led to a lot of tribal communities really being very concerned and being very critical of the federal government and of research as a whole. So it's really important that we think about the cultural competency and how we're engaging the communities so that we don't commit some of the unethical practices or issues that has been placed upon tribes in the past. So these are some of the strategic goals that we are currently employing. And I wanted to go back and talk a little bit more about our NIH Tribal Advisory Committee. And what's different about this group of advisors is that they come from, and they are elected tribal leaders, or they are designated officials from tribal nations. And here you can see on the map on the right-hand corner here is that these individuals represent large areas which we identify as IHS service areas. And they're broken up this way based on tribal representation. So you can see here that we have representatives from the Nashville area, from Oklahoma area, from the Albuquerque area. And it's really important that each of these representatives be able to effectively communicate all of the different things that are happening within the TAC and the NIH to all of the different neighboring states that they represent. So this is actually how we were able to be really effective in engaging tribal communities around the COVID-19 response. And I'll talk a little bit more about that a little later. But this group really has provided us a lot of direction in terms of what are some of the really important issues that need to be brought to formal consultation so all tribal communities can have the opportunity to provide input on a specific topic. Some of those topics include how to effectively address the opioid epidemic. This was immediately prior to the COVID-19 pandemic. We've also had consultations on NIH policies like the data sharing and data management policy, which is really important because tribes are concerned about who has their data, how is their data being stored, how is it being handled, and who has access to the data, and also who's giving permission to share that data. Also really important consideration when including tribes in biomedical research. So some of the things that we are really proud of, and I wanted just to go over a couple of these, is that we feel like we've really been working hard and developing strong relationships with not only the tribal communities, tribal leaders, but the tribal communities as well. Something that we've recognized through experience in our office is that getting tribal leader consent is really important, but sometimes because of the diversity and the complexity of communities, it's really important to engage those trusted individuals that may not be elected tribal leaders. They may be traditional healers, they may be elders of the community. So it's also important to recognize, again, the diversity of each of these different communities and being able to effectively communicate with them and build relationships with them so that they feel comfortable in reaching out to you saying, you know, Dave, we really want to focus on this particular area. Can you help us get there? And it's our job to make sure that that happens, or at least to give them that opportunity to do so. Something here that I had mentioned briefly is that we've worked with tribes who are very interested in participating in the earlier stages of the COVID-19 clinical trials during the vaccine development, early stages. And we were very successful in this. We developed some groundbreaking agreements. And I think something that was really eye-opening to me, which really shows a shift in how we work with tribes, is that the pharmaceutical companies went to great lengths to extend and provide exemptions for the communities because they saw how important it was to have them included in the phase 3 clinical trials of the COVID-19 vaccines. And with these concessions and with these agreements, it really ramped up and elevated tribal participation, tribal communication, and tribal efforts. And I think some of that has been relayed, as you've seen on the news, where tribal members have actually had the highest rates of vaccine uptake of all racial and ethnic communities in the US. So it's a shift from how pharmaceutical companies and how the agency has engaged with tribes in the past. And it really showed us that these communities are really open to participating in research when given the opportunity and when it's done respectfully. Another thing that we've done is participated in the Traditional Medicine Summit. So we actually convened the largest number of traditional healers to talk about the interface from Western science and research and how that would, is traditional medicine able to fit? Are they able to be put together in some coherent way? Is there a space for Western science and research and traditional medicine? And the answer was ultimately absolutely yes. Now, there are many things that the communities wanted to keep sacred and private, but there are opportunities where research would play a pivotal role in demonstrating the efficacy of traditional practices, which many tribal communities have practiced for centuries and have demonstrated that they worked for centuries. So this is where we've been thinking about traditional medicine and Western science and how they might interface. Also, the traditional community was really adamant about how do we provide our next generation of individuals the opportunity to practice traditional ways of healing, as opposed to running down to CVS and picking up, your pharmaceutical compound to treat either acute or chronic conditions. So that's really important for the communities also, and we responded to that. We're also beginning to think about a number 2 once we get this Delta variant under control. Some of the things that we also do is a lot of technical issues, continue to help our institute centers and offices form strategic alliances and really important and equal partnerships with tribal communities, and also helping them to identify who are the important individuals that they need to be speaking to when these opportunities for partnerships come up. So here you can see we've been also working with the Indian Health Service to really take a deeper dive into what are some of the issues of why research is not getting into tribal communities. And IHS has been partnering with us on that. So I talked a little bit about some of our accomplishments, and none of our accomplishments would have ever been possible without the terrific partnership with all the different institutes and centers you see here. This is just a very short list, but it just kind of gives you a sense of the broad scope of engagement that we have in the Thoreau office as it pertains to biomedical research. We heard this earlier. I heard the conversation about training and bringing up the next generation of AIN nursing researchers. You know, there's opportunities that we've been able to develop with NINDS and development of regional training hubs. And this concept gives high school students in their local areas, because many of the tribal students really weren't comfortable with making that big jump from their communities all the way to the East Coast and participating in an 8 to 10 week internship experience. So what we've done is develop that collaboration between a local academic institution, the local community, and the high school students, and giving them that opportunity about the expectations of when they do come to the East Coast, kind of making a pathway for them so that they can see that clear pathway to their, you know, their careers or their professions in biomedical research. So this is where I think, Dr. Zink mentioned the development of NINR's strategic plan, and these are some of the things that will be included in the final form of NINR strategic plan. But just looking at some of the important things that are going to be included, there's so many areas of opportunity where we would be happy to participate and collaborate with NINR and with the council in thinking about some of these really important issues. Some of the things that we're really focused on are building the research capacity through research internships. I talked about the regional training hubs, also talked about some of our efforts with tribal colleges and universities, but also thinking about the ethical inclusion of tribal communities and their ability to participate in clinical research. And not as just participants, but also developing those, the next generation of clinical researchers to actually conduct this research with their community members across the country. And then I did talk about the importance of tribal consultation and what that means in terms of really full participation by tribal communities in NIH research initiatives and efforts. So I like to include this. This is something that we really heard from a lot of the tribal communities, and I think a lot of us, it resonates with us today. You know, this is before Delta variant was identified, and you know, we have another variant called the Mu variant, which we're closely monitoring. And everybody's really tired, but we really need to think about how we protect our communities. And so I really, this is a quote that I shared with our Facebook community, and it's really resonated. And I think it really rings true today. So with that, I want to thank you for the opportunity. If you want to reach out, and you can look us up on the website, all of our contact information here, our strategic plan, and some additional resources that we have on our Tribal Health Research Office webpage. And with that, I would be happy to answer any questions.
Thank you so much, Dr. Wilson, and thank you for everything that you're doing. It was such a great overview. So we've asked Dr. John Lowe to help lead our council discussion. Dr. Lowe.
Officio, Dr. Wilson, it's good to see you again. I'm waiting for my camera to be enabled. It says it's unable to, here we go. Great. So great to see you again. And Wadon, thank you for that great overview and that really detailed overview. And I really love the logo art, by the way. It's really really, really nice, and it's great to see. So thank you. You know, as a native nurse scientist, we've waited a long time for your office and this office, and so we're so honored that we have you there, and we have this office at NIH to represent us and to give us the assistance we need. And so I'm leading the discussion today for the panel. And so my first comment, I think I'll just make a comment, you know, as Native people, we find that most communities really respect nurses in a great way. And we also find that when nurses, both native and non-native, are on either leading research endeavors or are participating on research teams, it seems to make a difference. And especially acceptability, you know, nurses are educated from a holistic perspective, look very closely at sociocultural, historical perspectives, current perspectives. And so I think it's really important to have nurses be representative in the research endeavors with Native communities. And so, of course, as you are well aware, we are very underrepresented as far as Native nurse scientists. And so we are working really hard to change that trajectory. I just accepted a new position at University of Texas School of Nursing at Austin, and we proudly claim that we probably have more Native nurse PhDs than any place else. So I have myself and a junior faculty member who's Native, and 2 postdoc nurse PhDs who are Native. So we are hoping to be able to do the work to develop a critical mass that we need. So, and we would appreciate any insight and assistance that you may be able to offer us. So thank you again, and I'll open it up to the other panelists, council members.
First, I wanted to say, Dr. Lowe, I did hear you make the comments about the critical mass a little bit earlier, and I think that there's a lot of opportunity for us to partner with the National Institute of General Medical Sciences, which is our big training arm of the agency, and thinking about how we can develop opportunities and make better linkages between up and coming, or those individuals who are interested in nursing. You know, I have 2 sisters that are nurses, and one of them is a retired Marine Corps sergeant. So she has a very different approach than the other sister, but they're both equally effective and very trusted members within their community. And so we need more of that. And you're absolutely right, especially in this day and age of COVID. Just thinking about once we get beyond COVID, there are so many other conditions that we have to keep monitoring. Mental health conditions. You know, the suicide ideations and completions are rising in tribal communities. So how do we address the mental health in other different areas within thinking about tribes? And nurses play an absolute critical role in this, being able to identify those individuals who are in crisis and providing them the attention and the resources that they need to overcome this.
Yes, thank you. Any council members would like to comment or have questions for Dr. Wilson?
John, I'll jump in just with a comment, Dr. Wilson. Again, a fabulous presentation. I love a few ideas that you mentioned. One is considering the office coordinating hub. I think that's just a great way to view offices at NIH. So I appreciate hearing that. I also love the idea of kind of the regional opportunities for folks, opposed to kind of what we've traditionally done is ask people to come to NIH or to move and relocate and move out of their families and cultures to do that. And as a comment, I think that we can learn from you in lots of other areas and how to be kind of adaptive and flexible in order to make sure that there is kind of like that pipeline and encouraging anyone, even with remote interest, to go into the sciences. So greatly appreciate those insights. And again, I think we can learn from you.
Thank you, Dr. Lee. We are very much looking forward to partnering with Dr. Zankin. What we do with the Regional Training Hub concept is there are different institutes and centers participate, and the funding that they provide, they usually carve out a week of curriculum. So NINDS is specifically focused on neurological disorders, and so they have a week-long curriculum talking about that. It would be great to have a week-long curriculum talking about nursing research and really highlighting that profession. I think just bringing awareness, a little bit of awareness will yield a tremendous amount of opportunity for us amongst the students.
So I have a question in terms of a strategic or a plan. I know that there's a need to build capacity of Native nurse researchers. And I'm thinking back in the late 80s and 90s when there were very few Hispanic nurse researchers. And how do you build the capacity and keep the momentum moving forward? Because there were a lot of non-Hispanic nurse scientists that were actually doing research in Hispanic communities. So is there a plan, as Dr. Lowe is help build the capacity of Native American and others to do that research to fill the gaps in for now?
Yeah, that's a terrific question, and it is about building critical mass. It's identifying those areas of opportunities that have been successful and leveraging those opportunities to be able to provide them resources. A lot of challenges that we see with many different disciplines is infrastructure and capacity, and that translates into funding, basically. And so how do we provide these areas or these institutes that have been really excelling at producing Native American professionals and give them the added resources to begin to expand that critical mass to where it becomes a community of its own? And that's exactly what we're trying to do here at the agency with the intramural research community as well, is building that community where people feel welcomed and they want to come to the NIH and they want to be a tenure track investigator here. So I think that those are the first steps in trying to identify and build critical mass. And then the opportunities are out there, like you had mentioned, there's a shortage. So there's no challenges in finding them places to train or to complete their training in that regard. Thanks.
Thank you, Dr. Wilson.
Are there any other comments? Go ahead. I'm sorry.
Oh, no, I was just, yeah, if anyone had any other questions. I've so appreciated working with Dr. Wilson and looking forward as we think about improving, inclusion in our supported studies and in our workforce to working closely with you, Dave, and hopefully your office in terms of those ideas and what's been successful, what we should consider. So we really appreciate that partnership that I'm hoping for as we move forward.
Absolutely. We're gonna bump that 0.2% up much more.
I hope so. And I know that we will.
Okay. Great. Well, thank you so much for the opportunity. It was really a pleasure to meet with you, and I look forward to our next opportunity where I can provide more updates about our progress.
Terrific. Thank you so much, Dr. Wilson and Dr. Lowe, for that great presentation and discussion. All right, we're moving right along. The next item on our agenda is concepts, which this is our first time and at least the last year to do this. So I'm going to start with a little reminder, including to myself, about concepts at NINR. So as I mentioned in my director's report, we're thrilled to have been included for a really nice increase in the president's budget for fiscal year 22. So beginning next month. To be prepared for that possibility, the staff have been preparing new concepts to present to you. The concepts are research program documents that come prior to developing a FOA. They're presented to council for discussion, comment, and feedback. Not all concepts will become a FOA. It depends on funding availability and other factors. Just to be clear, we don't take feedback on FOAs themselves, as that would put you in conflict to apply for that possible opportunity. So all the concepts that you'll hear today include some aspect of health disparities, as the $20 million in the president's budget targets that important area of science. In addition, these can be thought of as broad topics that address pressing needs that nursing research can address. So with that introduction, I'm going to turn it over to Dr. Rasooli. So Dr. Rasooli is our acting director of the Division of Extramural Science Programs, and she will introduce the staff for each of the concepts. So Dr. Rasooli, there you are. Hello.
Hello, and thank you so much. It's really a privilege to come to you this afternoon with just a few of the things that we've worked so hard on over the past several months. And I also want to thank our council members, the 6 of you who agreed to review these concepts prior to council and who will be leading the discussion about each concept. So actually, the first concept is a workshop proposal. And by kind of the arcane rules of the government and so on, this is not strictly a concept because we could in fact hold a workshop, but we value your input. And most importantly, we also want to discuss with you some of the directions that we see are extremely important going forward. So this first concept is, as I said, a workshop proposal. And I'm going to share my screen, or at least try to figure out how to do that in one moment. Very good. So the workshop that we want to hold is called Health Impacts of Implicit Bias in Machine Learning. And I was assisted in developing this idea by my very able colleagues, Rebecca Fang, who was snatched up from our intramural program to join NIDA just a month or so ago. And my colleague, Rebecca Goodwin, who we borrowed from the National Library of Medicine for several months last year, and who provided tremendous insight and expertise. Let's see if I can persuade this to go forward. Oh, yes. So what is algorithmic bias? Algorithmic bias is a systematic and repeatable error in a computer system that as a result creates unfair outcomes. One thinks of machines as being strictly logical and not being unfair, but in fact, if they're not programmed appropriately, then they will create unfair outcomes. So suppose your training set of data for your algorithm is too narrow. You train your facial recognition algorithm using the faces of white males only. You then get high error rates with other groups. And in this sort of groundbreaking paper that was published and then summarized in Nature, you can see that the false match rate goes up enormously, 50-fold when you're using females of different or males of different races. Another example would be pulse oximetry devices, who were developed and they use and trained using white-skinned people to measure blood oxygen, but then it turns out they don't particularly perform well in people with darker skin. So that's a bias that's introduced simply by not training your machine properly. You can also introduce bias by what's called label choice or measurement bias, where you're making in your mind an equivalence between different things and programming the machine accordingly. So this was a very important paper from 2019 where they looked at high-risk care management programs used by many healthcare systems and insurers. And one of the things they want to know if they're going to refer people to specialized and therefore perhaps more expensive or more invasive care is what their future clinical risk is. So the algorithm used a perfectly good idea. It said, well, we know how risky they are based on how much they've spent on healthcare in the past, using this as a surrogate for their health conditions. How poor is their health? We'll use this to represent that. However, costs represent how much money is spent on people, not their actual health status. And it turns out that when you look, more money on average is spent on white patients than on Black patients. But if you actually look at the patients going into the EHR, and this is a hard to understand graph, but the number of actual chronic conditions in the purple line for Black patients was much higher than that of the white patients at any given score in this high-risk care management scoring program. Two different kinds of ways of introducing bias. So this is a problem that is being widely examined now, and I just picked a few places on the website from our sister agencies, from major journals, the New England Journal and Health Affairs. And the question, there's been some what I would call stamp collecting, a lot of people looking at the problem and noticing it and calling it out, but what are the kinds of solutions? So the authors of that 2019 science paper said, what we really need to do to get accurate labels, to the labels that we give to the algorithm, is to have a deep understanding of the domain, the ability to identify and to extract relevant data elements, and then the capacity to iterate and experiment. In other words, we need to understand the problem better, or in the case of health, we need to understand health and healthcare better. I think there's another way of saying the same thing, and it's something that Shannon Zank said, which is that when you're talking about nursing science, you're talking about a holistic perspective. And genuinely understanding the person who's standing in front of you in terms of their entire health and the clinical and community settings that are responsive to the realities of their lives. In other words, nursing science can really inform the development of algorithms by adding, as Obermeyer and his colleagues said, a deeper understanding of the domain that's being modeled with the algorithm. And so we are proposing, in fact, to have a workshop that asks specifically about how nursing science can help detect and prevent unintended or undetected bias from machine learning algorithms. And to identify through this workshop gaps in research and funding so that we can aim new research and funding efforts to understand and mitigate bias in machine learning using the perspective of nursing research. We'll have some keynote speakers, try to draw people from different perspectives. We'll have some research talks, and I think this will be a highly attractive workshop, and hopefully we'll get some junior investigators and trainees, and perhaps have a poster session and some lightning talks so we can hear some of the really cutting edge things being done by the most junior investigators. And we'll look forward to having some collaboration with our colleagues from NIST and ARC, from the American Medical Informatics Association, and so on. So with that, let me turn it over to our two discussants, to Dr. Monroe and Dr. Lewin. And perhaps Dr. Lewin, you mentioned this earlier in your comments, so we'll start with you.
Okay. So I'm here. I think that this is a wonderful opportunity, and I think that I would even go that far, but I would refer to it as pioneering, because it touches upon something which everybody is concerned about, but in my humble opinion, the devil is in the details. So you have a tremendous amount of criteria which would bias the database. So I think that one of the critical issues here is definitely bringing nurses, but what would also be needed is to prioritize the topics which you are going to handle. You mentioned a couple of them, like the color of the skin and What was the other one? I've already forgotten, but anyway, that's very well documented in the literature. There may be a tremendous amount of those criteria. We just heard a talk about tribes and variety and diversity within the tribes. And that would apply to almost all people who are taking advantage of a healthcare. So my suggestion would be, before the workshop, I would try to identify what are the most important and the most critical issues from, let's say, point of view, and sorry to bring finances here, return on investment. So how much can healthcare systems save if particular criteria will be considered and the database will be developed in a correct way? Let me stop here. I don't want to be the only one who is contributing to this discussion.
And Dr. Monroe.
Oops. There we go. I think I have my mic on. So I thought this was a really interesting topic and important, because understanding the insidious effects of algorithmic bias could really help to inform nursing science and could really improve the rigor of the work that we do. I also think this area, despite other institutes sort of doing workshops in this area, has been under-examined to this point, and particularly in nursing science. NINR seems like it's well positioned to lead the planning and offering of the workshop. I know that last year and this year, the NINR methodology boot camps have been focused on artificial intelligence. And yesterday was the first of the 2021 AI boot camp series, and the first speaker in that was Dr. Robert Lucero, whose presentation was really focused on concerns about health equity related to AI algorithmic bias. I also noted that the third session of the AI bootcamp this year, which is going to be held on Monday, September 27th, is entirely devoted to that exploration of algorithmic bias. So that might provide a nice framework for moving the topics of the workshop forward. A workshop does seem to be the next logical step in developing the expertise among nursing scientists in recognizing and dealing with potential bias. And I would also say that I was wondering, as I read the paper, who might be NINR's partners in the workshop. I'm happy to see the slide that kind of outlines some of the potential collaborations. It seems like National Library of Medicine would be a natural partner for this work, given the work that they have done in machine learning and AI. And I'd be really interested to hear how other ICOs might be involved and how that might broaden or change the direction of the workshop to involve other groups. And I would open it to comments from other council members. Christopher, you have your hand up. Dr. Lee.
Yeah, thank you. I again, confirm enthusiasm about the workshop. I think in nursing science in particular, I think AI and machine learning have been pitched with insufficient equipoise about added value along with serious harms that can occur because of exactly these type of biases. So, some equipoise in presentation. Number one, I think a lot of folks are not convinced of the added value over other ways of predicting and identifying those more at-risk outcomes. So that should probably have some attention in the workshop, because if there isn't added value, then we shouldn't do it at all. But never mind the presentation simultaneously with the specific harms that might occur. And my second point maybe is the labeling of those concerns, because In AI and machine learning, we call them bias. In the real world, we call it racism and ageism and sexism and other things. So to be very explicit about the type of specific harms that occur because of these biases and label them exactly as they are, I think is also important thing to consider for the workshop.
Thank you. Other comment? Well, Dr. Holmbeck.
Thank you. This is really interesting. I'm curious about the. I don't know a lot about this area myself, but I'm curious about the scope of the problem and how broad this workshop could be. In the sense that is this well known in the AI world, such that they have lots of examples of this, not just in related to the topics you discussed, but in other areas as well, and so that we can learn from those as well as the healthcare biases that you were talking about.
So if I may add, I think that it would be good to invite a few people who are specializing in development of the algorithm, because it's not always possible to implement everything or every criteria which we really would like to know. Again, this is slightly off the area of my expertise, but I work with a couple of people who are doing deep machine learning, and I know what the problems they are facing. So this is maybe something to consider.
Oh, I think that I think there is a lot of chatter about this and a fair amount of publication. But you know, so to your point, Dr. Holmbeck, I think we'll be able to find people to speak on this topic and to speak about examples.
And I'm just trying to share my own experience. I have to tell you that coming from the engineering background, and I gained tremendously from my collaboration with nurses. I can say that my breadth of science probably increased by 2 orders of magnitude. So bringing together nurses and computer science algorithm developers would bridge the gap, which is really very serious right now.
All right. So thank you for all those comments. I'm busy writing all this down, and thank you. And you know, I hope that we can feel free to engage with you as the agenda is developed, and perhaps get some more suggestions and insight. And so thank you so much for this. We're now going to turn to our first formal concept presentation. And this one is called Advanced Integrated Models of Care to Address Racial Ethnic Disparities in Maternal Health Outcomes. It's going to be presented by my colleague, Dr. Shalonda Bynum. And the discussants, after she presents the concept, are Dr. Perencio Vasquez and Dr. Johnson. So Shalonda.
Good afternoon. Hopefully you can see my screen.
No, actually, it says you started sharing.
Okay.
But nothing is showing.
We'll try again.
Oh, perfect. Now we see your PowerPoint.
Okay. Okay.
And do you want to switch screens because we're seeing your preview?
I see. Okay.
I think you can switch up top where it says display settings. I think you can switch to the other screen, I believe.
Yes.
Swap presenter view and slideshow, that one.
Okay. Thank you very much for that introduction, Dr. Razzulli. So my name again is Shalonda Bynum, and I am presenting the AIM concept focused on improving maternal health outcomes among racial and ethnic minority women. So this concept was developed in collaboration with NINR colleagues, Dr. Razzulli and Dr. Henry. So there are stark differences in maternal health outcomes along racial and ethnic lines. Black, American Indian, and Alaskan Native women are 2 to 3 times more likely to die from pregnancy-related complications compared to Asian, white, and Hispanic women. So the CDC does not collect data on severe maternal morbidity. So these data come from state-level population-based studies. And this here that's presented today is out of Washington State and shows that compared to white women, all racial and ethnic groups are at a disproportionate odds with similar to mortality, Black and American Indian women bearing a higher burden. So the reasons for these disparities are complex and multifaceted, but largely rooted in a system of unequal access and unequal treatment. So there are social risk factors related to access to healthy foods, which can then impact pre-existing conditions such as overweight and obesity, transportation barriers, particularly for women who have to have small children at home that they also need to transport to appointments, housing instability. So if a woman is being evicted or displaced, she is less concerned about getting to a doctor's appointment and more concerned about shelter for herself and her family. And additionally, these social risk factors create stress throughout pregnancy, which adversely impact outcomes. Patient level factors such as awareness and knowledge of potential warning signs of complications, pre-existing conditions, I've already mentioned, and as a woman ages, her risk of adverse outcomes also increase. Additional factors related to the care team being inexperienced when pregnancy complications arise, care coordination, particularly for those women with pre-existing conditions, coordinating care for usual OBGY care, in addition to specialized care, and provider factors such as implicit bias, which can then translate to unequal provision of care and negative patient experiences. So we know that these traditional models of maternal care are less effective for racial and ethnic minority women. And we know that based on the epidemiological data. So we need to think more innovatively about how to support women within the system that is not working as well for them. So there is existing and emerging literature that suggests that labor support provided by a nurse midwife, a doula in the context of group-based care does reduce the risk of preterm birth, cesarean delivery, and emergency department visits, which can sometimes be related to morbidity and mortality outcomes. We know that navigation improves healthcare access, coordination, and continuity of care. And as presented earlier, any model of care that seeks to improve outcomes, particularly for women that are at heightened risk, must address the social risks that the daily experiences that women live in. So what we need to know, the data presented in the written concept and here today is limited in scope. So we really need larger scale evidence on the effectiveness of supportive care. Additionally, how integration of care that addresses social risk, in addition to direct medical care, pregnancy care impacts morbidity and mortality outcome. So much of the data has focused on those intermediate things such as cesarean delivery, which in some studies increase risk by 40 to 50%. We need to understand more about the American Indian and Alaskan Native population. So this population, despite being at disproportionate odds of poor outcomes compared to white women and other groups, has been understudied. So we really know very little about this population and how to optimize care. So this concept seeks to fill these scientific knowledge gaps by categorizing, developing, implementing, and evaluating integrated care models to improve outcomes. And by integrated care, I mean care that incorporates pregnancy support, such as through use of a doula for delivery, labor and delivery and postnatal support, incorporation of social service providers to address issues related to social risk. And these factors are really characterized in 3 different categories. So intending to impact healthcare access, healthcare quality, and social risk. So the thought is that integrated care that provides support in areas of need, both in and out of direct medical care, can buffer the effects of a system that has really underperformed for racial and ethnic minority women. And we believe that this concept is a viable path forward. So there are 2 different objectives. So a formative research objective intended to really understand ways to improve outcomes among populations that are understudied in the current literature. And also the conduct of pilot or feasibility studies of these models. So for PIs that may not be ready for a full-scale randomized controlled trial, allowing opportunity to pilot some of this data that can then be supported in a intervention trial. And the purpose here for the formative phase is to gain a better understanding of opportunities to improve health outcomes among, again, populations for which we know very little about. Secondly, to implement and evaluate integrated care models that address, again, healthcare access, healthcare quality, and social risk through the provision of supportive care. And the measures of success here are reduction in severe maternal morbidity as defined by the CDC, and mortality if sufficiently powered to do so. Thank you all for listening. I will stop sharing.
Thank you so much, Shalonda. Let me turn now to Dr. Provencio Vasquez, if he would like to make some comments.
Yes, thank you. After reading this concept paper, I thought of 3 areas that I'd like to share with the other council members and others in this call to consider and to start the conversation. The first point or the first thought was right away after reading this concept paper, I thought of the nurse-family partnership that has been in play for 4 decades. And it's really focused on first-time mothers, vulnerable first-time mothers, in mostly communities of color, and really walking them through their pregnancy. And it really focuses more on the infant and the health of the infant, but there are some data points for maternal care and maternal outcomes. So I think that's one project or program that we would like to really look at and further develop this conceptual framework of this integrated care model. So that's the first thought. The second thought was the integrated model really talked about community, and then it talked about healthcare systems. And so one of my thoughts were, it's going to be critical, and it was one of the objectives that there is a strong partnership between community, where these women live and work, and the healthcare systems that they are receiving care. And we talked about doulas and midwives, and I know that there's other healthcare, non-professional healthcare providers within communities, and Native American, Alaskan, as well as Hispanic, like promoteras. So I think these need to be considered in this integrated model. But back to that partnership, I think I would really want to know in detail the bridge between the community support that these women are going to be receiving, and once they enter the healthcare system to deliver, that patient navigator is going to take over. So where's the handoff? And then where's the handoff back once the woman has her infant and it goes back to the community? So to me, I think that piece is going to be very critical, that partnership between the healthcare system and the community where they live. And then my third thought was, and to follow up to Dr. Wilson's presentation, was the American Indian, Alaskan Natives. I mean, I think there's a great need of really looking at that community to see how we can minimize the mortality, morbidity of women having children. So those are my thoughts, and I'll turn it over to my colleague, Dr. Johnson.
Great, thank you. Those are some excellent insights, and so I'll see what I can add. First of all, Shalonda, it's good to see you again. We've interacted in your prior role at NIH. Great. What comes around goes around. It's great to see you. Yes. As I read this concept, every time and I'm not an expert in this area, but every time I learn about these, the wrong direction that these numbers are going, and how between, in recent years, the increase overall, in particular, in maternal mortality and the increase in the disparities, it really, it's just striking. And that, for our healthcare systems to not be responsive in a way is really alarming. And so I'm very glad that this concept is going forward. And as I had a lot of thoughts as I was reading through this, and as I was reading through it, some questions that came up were, understanding, in particular, looking at the different groups that we've talked about, the different racial and ethnic groups, understanding what seems to be working better for Hispanic women that's not working for the other groups, and trying to get a sense from what, and granted, the rates are still not fantastic, but they are better rates than for non-Hispanic white and for African American women. And understanding what are the socioeconomic or their cultural differences, because learning about how some groups are doing better can help identify areas for groups that are not doing well. And I couldn't help but think about how, the numbers that we had, I think, were through 2018, and it just made me wonder what the COVID-19 pandemic has done for all the reasons, for the way that it touches on every one of the factors that are outlined here. I don't know if that's it's couldn't have improved things. And then finally, I was also wondering, well, not finally, but I was also wondering about whether there are differences among the groups in early care for their pregnancy, among these groups, because that has implications. If, for example, African American women are more likely to seek care later in their pregnancy, that has implications for what the integrated care models might look like, and how do you engage earlier and consistently. I thought there were so many factors that were fertile ground, so to speak, for intervention in these models. One of the things that I thought was, because these factors, they are at multiple levels, they're at the individual level, the societal level, there's the family level, there's so many different parts that I think for interventions that ultimately come out of this, and for the formative work that this type of concept could support, I really believe they need to be guided by some theoretical or conceptual models, just because otherwise, if studies tend to just hone in on one particular factor without the full context for all the other things that are going on, it's going to result in perhaps unsuccessful or piecemeal findings that are going to be really limited in terms of how they go forward. And then also thinking through whether some of the disparities might be associated with lack of integration currently, if that's part of it, for other services that might be critical, whether it's mental health services for depression, anxiety, whether it's other services for tobacco, alcohol, or drug substance use, whether those services are not appropriately integrated in a way that works across all groups, whether that comes up as a model. And also, I just think too, and this I think you hit on with your slides nicely, is just the differential flexibility and options that, in particular, lower income women are likely to have. And so whether that's with flexibility with their jobs, the luxury of changing their work hours or changing their or even going on bed rest, if that's what's indicated during their pregnancy, and how that's very different depending on someone's financial situation and their employment options, and how integrative care can really work within those contexts to make sure to address that. So again, a lot of exciting opportunities, overwhelming opportunities in terms of what can potentially be driving these disparities. But my biggest, I think, take-home message is that this research should be guided by conceptual and theoretical models. It could be something more general, like social ecological, or something much more specific to this work. But I think that a framework is needed. But this was exciting, and I'm happy to see this moving forward. Thank you.
Yeah, thank you, Dr. Mallory, for those comments. I think they are all excellent. And there is a framework for maternal health. So we would definitely, if this moves forward, be embedding a framework within it. I think it's very important as well. So in terms of what is working well, I also think that's a very important aspect to learn, and hopefully that can come out through some of the formative research phases. So we know what the barriers are, but also knowing what the opportunities are. So what's working well within communities, so then that information can be disseminated. I think that's another very important piece. And to the earlier comment about community involvement, it is definitely a community. So I included community health workers. So there it would need to be, especially for communities for which we know very little about, and also to guide intervention, implementation, and evaluation. There is going to need to be a community tie. So in terms of organizations that work with young women or women of pregnancy age to address some of the social risk factors, because the traditional model of care is not doing that as well. So kind of bridging the gap. So the integrated model is intended to bridge the gap in terms of social care and understanding that women live outside of pregnancy. So when they go home, they have challenges in terms of getting access to healthy foods or transportation, or they're not having a flexible job in terms of getting to appointments. So those aspects are definitely important. So thank you for those comments.
There are other thoughts from the council members, other discussion points. Dr. Lowe?
In reflecting on what was presented, and thank you for that presentation and the discussion, it's a very needed one. I reflect on how in Native communities we prefer and many times require that community-based participatory research approaches are used in conducting research. And so I think part of the challenge is that so many times in proposals, that approach is not very well articulated, or the principles around it. And so I think there may be a need to really have a focus and on how to delineate principles with Native communities, and especially with this topic. And so that may need to be either revisited or reconceptualized. Thank you.
That's an excellent point. Are there other comments?
Do you mind if I jump in? This is Christopher Lee. So I have two kind of reflections, and they're a little bit conflicting. You know, the first is that at first blush, this just screams nurse midwifery, nurse midwifery, nurse midwifery, who have had for many years ways of doing group prenatal care and adapting care to fit the needs of communities. Is that a midwife is the highest level of service to whom many women.
Oh, Dr.
The
Lee,
role.
you're
I'm sorry.
fading in and out.
I'll hold it a little closer to my face. I would just augment the mention of nurse midwifery, because I think historically they played a very large role and probably already have a lot of the solutions, and many of them ready for the implementation phase. So my other comment is the concept is a little bit agnostic to the reason that women actually die. Directly related to maternity issues. Pregnancy is a stressor to women who are already at massive risk for cardiovascular events, and cardiovascular events is still the main reason for mortality short-term after pregnancy. And so as much as I love the highlighting of nurse midwifery, the other types of community health care workers and other healthcare services that can help minimize long-term and short-term cardiovascular risk after pregnancy, I think also should have a very prominent place.
All right, those are excellent. Yeah, thank you.
Yeah, I definitely agree. So we know that at least for mortality, 60% of pregnancy-related mortality can be prevented. So yeah, thinking comprehensively about the care teams that, and it will differ depending on the population and region, et cetera, but thinking more comprehensively about how to address all of these aspects of healthcare quality, access, and social risk that put women at disproportionate odds for poor health outcomes. So yes, that's definitely an important comment.
All right, so I want to thank you all and thank Shalonda for presenting this concept. And so finally, for our final concept, I'm going to turn to my colleague, Amanda Price, and she's going to present on addressing long-term social impacts of the COVID-19 pandemic on health and health disparities. And the discussants are going to be Drs. Holmbeck and Lowe. And Amanda, also, if you could swap your screens. Yeah.
Okay, can you see my presentation now? Are we good?
Yes.
Okay, great. Thank you. So the concept I will be presenting today is addressing long-term social impacts of the COVID-19 pandemic on health and health disparities. My name is Amanda Lee Price, and I'm a program officer at NINR. And this concept was developed in collaboration with NINR staff. And here today with me are Dr. Karen Huss, Dr. Lois Tully, and Dr. Shalonda Bynum that you just heard from. When we think about the impacts of the pandemic, the COVID-19 pandemic is a health crisis. However, it is also a human, economic, and social crisis as defined by the UN. It has affected every aspect of our lives, and we are all still living it right now. Racial and ethnic minority populations have been disproportionately impacted by the pandemic, both directly in that they're more likely to contract COVID-19 and to experience worse outcomes, but also indirectly in that they're disproportionately represented in essential workers. They're not been able to social distance and follow COVID-19 precautions based on where they live and work. And of course, this is also on top of existing health disparities. Two unexpected consequences of the pandemic have been related to food and nutrition insecurity, as well as housing instability. And if you look at the graphic at the top left, that's a picture of some of the historic lines that have been at food banks during the pandemic. And the other picture shows a banner that says no job, no rent. So many people are affected by the economic crisis of this pandemic that also affected their housing and their ability to access nutrition. And food and nutrition and housing are two important social determinants of health. Social determinants of health are aspects of people's lives that affect their health, their functioning, and their quality of life. Healthy People 2030 breaks the social determinants of health into 5 primary domains, and nutrition and housing fit naturally within the neighborhood and built environment, social and community context, as well as economic stability. However, where people live also affects their access to and quality of both education and healthcare. And furthermore, schools are a primary source of nutrition for children. So both nutrition and housing really play a role in all 5 domains of social determinants of health. This pertains to nursing due to the alignment of the holistic health and needing to consider the realities of people's lives in disease prevention and health promotion, which is important in clinical and community settings where nurses practice. Furthermore, population health is one of the domains of nursing practice as defined by the American Association of Colleges of Nurses, and particularly in relation to this concept is the priority of advancing equitable population health policy that is part of nurse science and nurse practice. When we look at food and nutrition insecurity, it is a health risk factor for both children and adults. Children and adults who are food insecure are more likely to have chronic conditions and to experience poor health. As depicted in this graphic, if you look at the bar at the far right, if you have very low food security, you have a 52.7% chance of having a chronic condition, which is much higher than if you are food secure. And that is data from the USDA. During the pandemic, food insecurity has risen sharply, and it is estimated from around 11% before the pandemic to 18 to 35% of US households after the pandemic, or actually during the pandemic, which is a significant proportion of people who are food insecure at this point. As earlier depicted, food bank use has also increased, and throughout the pandemic and even more recently, supply chain issues have affected the availability of foods, which has just worsened food insecurity. Housing instability is also an important health risk factor, and substandard housing increases the risk of chronic diseases. It also reduces the availability of physical activity and nutrition resources like proximity to parks and walkways and lighted sidewalks and so on that are safe to participate in physical activity and exercise, and also the proximity to grocery stores or other healthy food sources. Furthermore, substandard housing is associated with reduced employment opportunities, which also reduces your ability to access proper nutrition and to live in a proper house. If you look at the picture, your house itself is not the only important factor related to your health. It's also the house's proximity to resources. And if you look at the bottom left corner, this house is located close to a bus stop, which of course provides access to the community. And so when we think about housing and stability, it's not just the house itself, but also its placement within the greater community. During the pandemic, greater than 50% of renters reported a high likelihood of being evicted as of December 2020. And this is as a result of many people experiencing financial hardship and losing jobs and primary income sources during the pandemic. We also know that poor housing increases transmission of COVID-19, as well as incidence and mortality. And that's particularly evident in crowded households. Furthermore, the CDC has concluded that stable housing is a critical part of the response to the pandemic because it's important for individuals who become ill or who are at risk of transmitting COVID-19 to be able to social distance, quarantine, or isolate from others. And I pulled this graphic from the CDC website, and even the CDC is depicting a stable family home as a 2-story single family home, which is just not the reality of a lot of families in the US. There have been many mitigation efforts put in place in order to try to reduce and minimize the impact of these two factors on health during the pandemic. So as it relates to food and nutrition, there have been changes in subsidized and free meal programs, particularly in schools. They have allowed parents to pick up school meals for their kids to eat at home, particularly during the homeschooling phase. There's been additional funding for food assistance programs, and they've also enrolled people to enroll in food programs remotely, which before was a pretty involved in-person process. As it pertains to housing, there have been a moratorium on evictions, emergency rental assistance and emergency housing. There's been elimination of single-family zoning, as well as mortgage relief. So that brings us to the purpose of this concept, which is to identify and address the ongoing and long-term impacts of the COVID-19 pandemic, focusing on these mitigation strategies that I gave examples of on the previous slide, as well as policies and interventions that address these two specific social determinants of health related to food and nutrition, as well as housing, security, and the resulting impacts on health. We also aim to understand the impact of health in populations who experience health disparities, especially racial and ethnic minority, and socioeconomically disadvantaged individuals, families, and communities. The scientific objectives of this concept is to analyze policy and programmatic interventions, as well as quantify the health impacts of such interventions to understand how they have or have not been able to reduce the pandemic's effects on health, and also to study them as potential approaches to addressing long-established determinants of health inequity. And lastly, we want to study these things in order to be prepared for future pandemic or future crises that come along. In terms of implementation and collaborations, we have worked with other ICs and been in communication with several that share similar interests and emphasis on understanding social determinants of health and addressing those, as we also aim to address primary health risk factors. We also would collaborate with the COVID-19 social, behavioral, and economic working groups. There's one focused on interventions and one focused on data science. And these are pre-existing working groups that have been around since the beginning of the pandemic, and there have been other funding opportunities that these working groups have worked to support. And that is all for my presentation. I thank you for your time.
Thank you so much, Amanda. I'm going to turn now to our two discussants. Let me start with Dr. Holmbeck.
Thank you. That was a really interesting presentation, Amanda. And as she talked about, there have been policy changes that have been made in order to address these two social determinants of health, specifically housing insecurity and food insecurity. And so one of the examples was the eviction moratoriums were put in place to reduce housing insecurity. So some of these policies likely have had positive impacts, such as the eviction moratorium, but other policies have probably had both positive and negative impacts. For example, social distancing and isolation has reduced the incidence of COVID, but probably also, has obviously increased unemployment rates, which have continued and impact negatively on future health, such as food insecurity. So, and also not surprisingly, these impacts are felt most strongly by our most vulnerable population. Some of these problems are newly caused by COVID, whereas others seem to be exacerbations of existing problems. For example, housing insecurity is intensified under COVID due to unemployment, which leads to crowding, as Amanda mentioned, which increases the risk of subsequently of COVID infection and then lack of quarantine. So I think I sort of see this like a natural experiment in a way that we can benefit from. It's an unfortunate natural experiment, let's put it that way, that we need to know the effects of the policies that are already in place, and we have this opportunity to evaluate policies that normally would not have been put into place. And are there lessons that we can learn from this, both positive and negative lessons for future, not only future pandemics, but really for changes that can be retained post-pandemic. And it would be interesting to have, for example, a cost-benefit analysis of these policy changes. And also, I'm a psychologist, so I have an interest in mental health concerns and child educational outcomes, and these are downstream variables from the factors that these two factors that you discussed. And I guess if this becomes an FOA, it seems I guess I would encourage it to be broadened to do. I thought that slide you had was really great with the social determinants of health. It could be broadened to include healthcare access and educational access, in addition to food and housing insecurity. And then that would bring in, collaborations with public health policymakers, educational people, psychologists, physicians, and so on. So I think this is really exciting, and I think we're benefiting. It's a silver lining to a tragic problem.
Thank you so much for your comments, and I'll turn to Dr. Lowe.
Thank you for that presentation, Dr. Price. And so my thoughts are that the purpose of the concept to identify and address the ongoing and long-term impacts of the COVID-19 pandemic is timely and responds to the mission of NINR and to the needs of the public as a result of this unprecedented global health challenge. The recent report from the National Academies of Sciences, Engineering, and Medicine titled The Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity, denotes in part that due to the pandemic, there is now deeper evidence and understanding of the different impact of generations of inequity associated with racism and bias, socioeconomic status, disabilities, financial poverty, and living in areas with decreased health access that has fueled compromised health status for many Americans. So the growing evidence for inequities in both health and access to healthcare has brought an added focus on social determinants of health. This concept will support studies that are needed to address the effects of the pandemic and advancing understanding about food insecurity and housing among underserved, marginalized populations. Intersectional knowledge projects aimed at studying the interplay of policy power dynamics within and across systems is needed to challenge the status quo between oppression and privilege, individual, institutional, and structural levels of power within a given social, cultural, historical context, or advancing health equity in relation to food insecurity and housing needs also needs to be explored. So studies grounded in this conceptual initiative can result in understanding ways to address the multiplicity of identities, social positions, and systems of intersecting inequalities related to food insecurity and lack of adequate housing for diverse populations of children, youth, and families, and move closer to affecting sustainable change and equity. And again, thank you.
And thank you for your thoughtful comments. I'm now going to open this to the rest of the council for your comments and thoughts. Any questions perhaps for the team?
Well, I do want to thank you, Dr. Holmbuck, for pointing out that a lot of these policies that were put in place have been things that people have advocated for a very long time and happen to be put in place because of this, kind of global crisis that affected everyone. And so this is a perfect opportunity, and to build on what you said, Dr. Lowe, a perfect opportunity to study these things because we have these policies and interventions have been put in place. And so we do need to understand how well they have worked or have not worked, what things they made worse, what things they made better, so that we can better design future policies and future interventions to address these factors, particularly in addressing health disparities as has been a key topic of conversation throughout our council meeting today.
Excellent. All right. Well, I want to thank Shalonda Bynum, Amanda Price, and all NINR program colleagues who have worked so hard on these concepts. We look forward to sharing more concepts with you in the future and really look forward to your input and insights, which help us shape our thinking as we move forward. Shannon?
Indeed. Thank you, Rebecca. I want to echo Rebecca's comments. This was so appreciative for the extramural staff who worked really hard this summer at a time when clearly people wanted a little break, understandably, with the pandemic, and were able to put these concepts together. So a big thanks to them for all their thinking and all their work. And again, we so appreciate your feedback on the concepts as we consider them further and think about next steps. So thank you so much. All right. We are getting towards the end of open session, but before we do, I do want to open up the floor for any questions, any comments, any announcements that the council has. So I'll turn it back over to you. Anything? Okay. Everyone's tired now. It's been a while since we've had a break. Well, while you're thinking, if you do have any announcements or questions or comments, I want to just go back to our earlier conversation during the director's report around diversity and inclusion, and just reiterate what I heard as some agreed upon next steps, which would be to form a pair of working groups of council to look at diversity of the scientific workforce that NINR supports, as well as a second working group to look at inclusion in NINR supported studies, and what NINR should be doing as we move forward to address strength and inclusion, strength and diversity of our workforce as we move forward. Dr. Old, our esteemed executive secretary, will be back in touch with council as we think about concrete next steps for that. So with that, again, I'll just pause and see if anyone has any announcements or anything they want to put on the table before we wrap up open session. Okay. Excellent. All right, so we will be ending our open session. Thank you so much to the council members, our presenters, and to all who joined today's open session and meeting of council. We will be ending here at 2:41-ish Eastern time. And I'd ask the council members to please rejoin at 3 o'clock Eastern. You should have a separate link to join. If you have any questions, please reach out to us. But otherwise, we'll see you in about 19 minutes. Thank you so much for a great open session. See you in a bit.
Thank you.